interventional surgical techniques for the aortic regurgitation. So before the TAVR process device applied in the people, it has been a long history. This is the animal test and early design for the TAVR animal experiment. We can see it's a long stem and the stuff. So in that time, people think the stent in the aortic will not move. So under the 2010s, the first case used for aortic regurgitation. This case is very young people with aortic regurgitation, but the very weak LVEF. But we can see the annulus is small enough. So this case used 29 core valve. This long stent valve is a self-expanding valve. And this article compare the first and the second valve. We can see the second valve, the success rate is very high, almost 80%. But the first, with many complications for PVL or PPM, is a very high rate. And this is the first self-expanding valve for the aortic regurgitations and many complications. So the best result of the TAVR valve you apply in the aortic regurgitation, maybe the J valve or J valve, and we use the J valve many cases. And the second of the J valve is used about 2 years, but it's not commercial. And this is export consensus of the TF TAVR for the Pro-AR in China. So for the small annulus, we can use the self-expanding valve. And this valve is used for the aortic stenosis, but we use the J valve or Yen valve. And the J valve is the most case we use. And this valve has 3 grippers, and it also the small and short stem, and like a crown. For the small annulus and also the LVOT, STJ, we can use the self-expanding valve. But if the annulus is too large or the ascending aortic is too large, and this is not good. And we can see this case is 69 after the aortic dissection. It's a Pro-AR and with a large angle. But we can see the diameter of the annulus is 2028. So we used weight flow 27 valve and with success. But the video is can't play. So okay, we can see this is the result of this case. It's the best result. And another case, this is Pro-AR. And in the CT evaluations, the parameter derived annulus is 29.3. It's very large and more than the largest size of the J valve. So if we choose the 29 J valve, it may be moved to aortic, ascending aortic, or the LV left ventricle. So we choose some strategies we use a patch and suture in the stent. We choose three patches, and in this way, we can enlarge the stent diameter, so it may be not move to the ascending aorta, and it can decrease the PVL. This is the process of we enlarge, suit the patch of the stent, and this is the result of this case. We can see the stent valve is the location of the stent valve is very well, and with no PVL, and this is the result of the echo. And another case, it also a poor AR, and also very large of the annulus. We can see the annulus of the perimeter derived is 31.9. It's very large. So we also choose this strategy. And we put 3 purliner. And this result of the post echo. This strategy has used in TABE. And this very complex. And this 73-old female, the LVEF is 39. We can see the aorta is very tortured. So the pigtail is very tough to move to the descending aorta. So we put the Landquest wire in the aorta arc, and then we put the J valve through the transapical access. And this is the results. And the J valve is a very good location, and with no PVL. The J valve has the second generation, and we used, I will show 2 cases. This case is a pure AR, and it also has a mitral regurgitation. And the CT evaluation annulus is 27.6, and STG is large. LVOT is 28. We can see no calcifications, and the Valsalva sinus of Valsalva is large, and the femoral diameter is good, and the process of the procedure, the angiography of the aortic. The second generation of the J valve, we may choose the good diameter of the femoral. The process is similar like the first generation, and we put the 3 grippers in the sinus, and then down the stent valve, and then release. And the result is very good. The post-operation, and another case, and this case is the process is very tough. We can see it's very taut and small patients. The aortic arc is very taut, but at last we choose the transfemoral, and this process. We compare the pre-operation and post-operation echo result, we can see the aortic regurgitation. And we use another stent valve. This is a king valve. It's like the G valve, but the three grippers is can't move. And this valve is used for the AR and it can also used for aortic stenosis. And another stent valve is a X-core. This valve is used through the transapical access. So for AR patients, we prefer J valve or in valve. If we don't have this valve, we can choose the second generation because it may a larger success rate. But for this patient, it may with small internal diameter of the annulus and the LVOT and the sinotubular junction. A surgeon must be on call to prevent early or late valve migrations. And patients with AR who have severe heart failure with severe dilation of the left ventricle and reduced ejection fraction may have a poor outcomes. Okay, that's all. Thank you.